We want to welcome you to the GI cancer session in Axiom series of ESMO town halls, in which we will be reviewing the latest data from the conference and speaking to implications for GI oncology. We're delighted to have guiding us through this program two highly esteemed medical oncologists, Dr. Pashtun Kasi from the University of Iowa's Harvard College of Medicine, who will discuss recent data in colorectal cancer, both in the adjuvant as well as metastatic settings, and speak about what practice-changing events we can expect both therapeutically as well as diagnostically. Following that, Dr. Dan Catenacci from the University of Chicago Medical Center will delve into the major trials presented at ESMO in gastroesophageal cancer, again, both in the metastatic and adjuvant settings, and which represent potentially major shifts in standard of care, with respect to immunotherapy in this therapy area. We'll then end with an open discussion, and so we encourage you to send your questions through the chat function, and hopefully we can get to your questions. And with that, I will ask Dr. Kasi to get us started.
Well, thank you so much for the opportunity. So what Dan and I were hoping to do was I was going to focus primarily on colorectal cancer, and you'll see a recurring theme, which is probably one of the biggest advances that's been like the buzzword. It's something to do with liquid biopsies. In this case, we're talking about ctDNA or circulating tumor DNA, referring to some of the trials that are now open and enrolling. And then with the recent approval of immunotherapy for first line, and I will also talk about some settings with reference to trials that are important in terms of the challenge using, again, circulating tumor DNA in the setting of metastatic settings. We'll also highlight some ongoing trials and topic of interest, and some of this would also blend well into discussion for our upper GI malignancies as well. Let's go on to the next slide, and briefly, just from a nomenclature perspective, you'll often hear these terms, MRD, molecular residual disease, minimal residual disease, circulating tumor DNA, liquid biopsies, ctDNA, cell-free DNA. All what it is essentially is pointing out to the situation is the situation where if somebody with stage 2 or 3 colon cancer in this case, for example, and all of these concepts would also apply to other GI cancers as we'll go through some data, and not only GI, but also other tumor types as well. Essentially what it's referring to, and some of these terms are borrowed from our colleagues who deal with blood cancers, is that if you're cured from whatever upfront procedure, in this case, for example, colon surgery to remove somebody's primary colon tumor, which could be stage 2 or 3 if it had gone to the lymph nodes, usually we do mop up chemo afterwards simplistically to cure them. And as we know, a lot of the patients may actually be very well already be cured from their cancer. May not even need any chemotherapy, whereas some are at high risk for recurrence and their cancer comes back. Right now, a lot of those decisions are based on what we call pathology variables, looking at the size of the tumor, looking at how many lymph nodes were involved. We also look at the presence or absence of something called mismatch repair, or the presence or absence of Lynch syndrome, because the risks differ in those patients who have that or those tumors who have that. Right now, all those tools are somewhat static, where we're looking at the patient characteristics and the tumor characteristics. We're not necessarily looking at characteristics dynamic in terms of, is there anything in the blood of the patient or something that can tell us right now who's the one who is at more risk for recurrence and may benefit from potentially an aggressive strategy, and who's the one who could be spared of the toxicity. I think that's where the current research and trials are focusing on, which brings us to the question of the current tools that are being used. And that's where some of these liquid biopsies are coming into play. It's a misnomer because there's no biopsy being performed. Essentially, you're doing a blood draw. And what some of the tools and technologies that I'll walk you through are trying to do is either they're looking at a tumor-informed circulating tumor DNA assay, where a piece of tumor is used, and then a custom-built assay is designed for each patient's tumor. So it's only relevant for that patient's tumor. So you can monitor that over time, as opposed to something that is more so relevant to the colorectal cancers in general. And those look at specific markers. Often these are what we call epigenomic or methylated markers, combined with mutational analyses that are generically can be used without any presence of tissue. So you don't need that, but also comes at the risk of potentially maybe false positives, as well as false negatives, because you may miss some of the patients whose cancers may not fall in that spectrum. Let's go on to the next slide. So essentially, where the field is right now, there are some assays that actually are already Medicare approved. The tumor-informed assays are. Uh, because it's a tumor-informed assay, the specificity of these assays is particularly high because there's no false positive in these scenarios, because essentially, if it is positive, then more likely you have cancer, whether or not we can debate and if it's minimal residual disease for sure, or some people worry and question the fact that we can detect cancer in somebody's blood. Is that already something like stage 4 disease? And that's a subject for ongoing discussion. But for sure, one thing that we can agree upon is the fact that the ones who have positive tests on these assays, those are patients who pretty much within 2 years of ongoing follow-up already have recurrence. And often the other theme is it's detecting recurrence 9 to 12 months before the scan's detected. So that's kind of ongoing questions for the field right now. I think the sensitivity of the assay, in my opinion, for some of these tests I think we're getting past that. I think the more so the question is how to use which assay and when to use them. And we'll go over through some of the examples in some of the ongoing trials and some of the data that was already presented at ESMO. Let's look at the next slide. And the other aspect that I wanted to kind of focus on, again, ctDNA or liquid biopsies are not meant to replace ongoing tissue testing. This is particularly true for metastatic setting, and it's particularly true for the question being asked. So while ctDNA is great for looking at point mutations, fusions are large gene rearrangements. So there are now drugs that are approved for NTRK fusion. Recently, there was very provocative data for RET fusions. We have ongoing trials under Colomate for FGFR fusions. ALK, ROS, and some of the drugs that are approved for NTRK fusion also act at some of these other fusions. These are rare events, but these are events that, as some experts may put it, should not be missed because these patients, even though they are small in number, they do end up getting a lot of benefit. And the other interesting thing that why liquid biopsy may be particularly useful is often these are acquired mechanisms of resistance to EGFR blockade. There's data from MD Anderson published a few months ago where these were detected more so in the RAS-RAF wild type post EGFR blockade. And we'll see how it blends well with another study that was presented at ESMO, which we'll go into more detail, so-called the CAVE study, which again looked at acquired mechanisms of resistance. So simplistically speaking, just like Darwin's theories of evolution and survival of the fittest, you have tumors change their treatment over time, their makeup over time. So some treatment options may become options if you detected a fusion in the course of treatment down the line. And some treatment options may not be a reasonable option, especially if you detected, for example, the presence of EGFR, RAS, or RAF mutations, which will pretty much jam the lock for ongoing EGFR blockade. Let's go on to the next slide, and let's talk about the adjuvant space where we presented on behalf of the bespoke group, the trial that is now open and accruing. We're actually up to 60 patients as of yesterday. Here at Iowa as well, we opened the study day before yesterday. So a lot of the sites are in the process of activation. But what this study is looking at is how ctDNA-directed tumor-informed assay could be incorporated into the care of somebody with stage 2 or stage 3 colorectal cancer. Right now, because of the discrepancy in terms of how people will be comfortable in incorporating or their decisions for adjuvant therapy be dictated by an assay, this one allows for physician-directed therapy. Actually, that's the main variable that's being captured. And real time, the results of the tumor-informed assay would be provided to the physician and the patient. And what they're trying to capture is if the decisions for treatment change as the results come back. So on the spectrum of treatment for anybody with stage 2 or 3 colorectal cancer, somebody go for, right now with all the data from the IDEA collaboration looking at 3 months versus 6 months. So somebody could go from no treatment to single agent capecitabine to doublet FOLFOX to doublet CAPOX to 6 months of FOLFOX to 6 months of CAPOX. So there are obviously a lot of patient variables that come into play as well, with lack of benefit, for example, for platinum in the elderly or for certain stage 2 instances. But as you can see, there's a spectrum of escalation or de-escalation. So to point out, the trial doesn't necessarily dictate what you should be doing for your patient, but it's kind of capturing, the MRD positivity rates, and also more so what we call like the seroconversion of somebody turning from positive to negative. And the adjuvant therapy really helped because we don't know the answer to that question. So the co-primary goal of this trial is particularly looking at, what are the MRD positive rates and how many patients do convert from negative to positive and vice versa on therapy and on follow-up. And secondarily, we're going to be looking at, how does that correlate in terms of recurrence over time? Because a lot of the numbers that you have right now are retrospective look at prospectively collected data that is hypothesis generating, but doesn't necessarily give you the treatment data in particular, because the treatment data for adjuvant therapy clearing MRD or ctDNA positivity is only a handful of patients. Let's go on to the next slide. And what I wanted to highlight here is essentially it's piggybacking on the standard of care. Because it's a tumor-informed assay, the patients could be enrolled 2 weeks prior and up to 4 to 6 weeks after their surgery. So the assay is custom built for each patient, and depending on their frequency of follow-ups, which is every 2 weeks or every 3 weeks, if they're getting adjuvant FOLFOX versus KPOS respectively, and then whenever they will be getting their CEA and scans, the tumor-informed assay is piggybacked on their care. And the turnaround, ideally, once you have a custom-built assay already developed, is going to be less than 7 days. And even for the ones where initially you don't have the tissue, from the initial sequencing, which can take about 10 days to 14 days, the follow-up blood results should be back ideally within 2 to 3 weeks, so that it's in the future, it's going to be incorporated real time, because as you know, adjuvant therapy in terms of mop-up chemo should ideally start as soon as possible once the patient has recovered, typically 4 to 6 weeks post-surgery, and not necessarily after a certain period of time. And we know from some previous studies, every passing month or every passing week, you do lose ongoing benefit as there's more time for the cancer to prosper. Let's go on to the next slide. And again, because it's a tumor-informed assay, there has been already published literature and publications for looking at MRD, because if you look at this assay doesn't necessarily have a specific signature that's unique to colorectal cancer. It doesn't necessarily have a specific mutation in terms of BRAF V600E or KRAS that we're following. It's essentially unique to that patient, and even for that patient, unique to that specific tumor. So you could theoretically use this assay in any setting as long as there is enough shedding to be detectable in the blood. At ESMO a few weeks ago, this was the results were presented for patients with esophageal cancer. And esophageal cancer, as we know, have a high rate of recurrence, and I won't go into details regarding those numbers because Dan is going to show us data on the IO trials where you'll get a sense of the high risk of recurrence in these situations. So having an assay could be of value in those situations to truly see who will benefit from some of the trials that Dr. Kanaki is going to talk about. Let's go on to the next slide to briefly look at the results. And again, the recurring theme is, if you're ctDNA positive, those patients recurred. And typically the recurrence was in the order of months, because obviously we were using scans to come up with the recurrence. And somebody who was ctDNA negative, again, these were a handful of patients, but the results were pretty black and white, again, going along the JAMA Oncology paper from May 2019, which was colorectal cancer. In these patients as well, with esophageal cancer, we're seeing a recurring theme. And not surprisingly, a lot of these patients, post-esophageal cancer, chemo, radiation, definitive therapy, and surgery, they don't necessarily get any further adjuvant treatment. So typically, as you're surveilling them, somebody may be negative and then turn positive as time goes by, or they were positive and you can see the numbers going up. So the other advantage of some of these tumor-informed assays is they do quantify it for you. And not surprisingly, it does go up. And there was also data presented and published now in Nature Medicine, including 3 other papers looking at ctDNA during immune checkpoint blockade, where the rise of ctDNA on always being ominous and a fall correlating with response. Let's go on to the next slide. And updates from an immunotherapy perspective in colorectal cancer. Immunotherapy first line in the United States is now approved as an outcome of Keynote 177. This was already presented at ESMO, as well as there was updates at World GI Congress as well. The major update at ESMO was the quality of life data. We know, in general, we assume and we think that quality of life is better for patients who get immune checkpoint blockade versus chemotherapy and the other tumor types. But as we can see on the next slide as well, here we talked about quality of life variables in terms of improvement and decline. And overall, on some of the quality of life scales that they checked, immune checkpoint blockade versus chemotherapy, overall, it was the functional status and everything else was better for patients who received immunotherapy, which is not surprising. But this gives value in terms of actual measurements as well and kind of sets the benchmark for future studies. Going on to the next slide. Again, other measures of scales, same improvement in terms of as opposed to chemotherapy. The other two key things to keep in mind is the short-term toxicity, but also there is the cumulative neuropathy for oxaliplatin or cisplatin-based chemotherapy, which may not be a deterrent early on, but then becomes a significant quality of life issue after the initial 4 to 6 months of therapy. Let's go on to the next slide. And how this will impact treatment paradigm. Before this data even came out in NCCN guidelines, pembrolizumab was already an option because, again, similar to like the fusions I talked about earlier, mismatch repair deficiency or microsatellite instability high or the TMB high tumors, these are, again, things that you cannot afford to miss because the amount of benefit in these situations is profound. And that's why this is the first indication, as we know, for which pembrolizumab has been approved agnostically, because again, the benefit is seen across tumor types and is profound, durable, brisk, and the ones who do respond, as you can see, the curves plateau out. So, I've seen the experts now increasingly use the word cure in these scenarios because that's how impactful care is in this situation. Let's go on to the next slide. So again, switching gears and looking at metastatic setting and how that impacts care, the key is, tumors evolve and change over treatment. So the understanding of, specifically right now where it's impactful is the RAF wild type tumors. And this is not just true for colorectal cancer, but other cancers too, where a lot of this is essentially profound for targeted therapies, not necessarily chemotherapies. And also, right now for colorectal cancer, it's probably relevant more so for RAF wild type tumors, because those are the tumors that can acquire mechanisms of resistance. Or the other hypothesis is, as depicted in this cartoon, that you may already have you may already have resistant clones, they just blossomed over time. Let's go on to the next slide. And this is already, being increasingly discussed, and I think it's, being adopted, or at least in Europe, they do anti-EGFR blockade more so than United States for first-line therapy, where somebody may get a doublet chemotherapy with anti-EGFR with cetuximab or panitumumab. They respond really well. The data is pretty profound. There was data for triplet chemotherapy, FOLFOXIRI with panitumumab that was published for Wolfie's study, leading to what we so-called conversion therapies or secondary resection. Now, again, these patients, they do respond, but at some point in time, they develop mechanism resistance. And that's what's depicted by the purple cells here. In my opinion, I think it's more so truly acquired, not necessarily present at baseline, because some of these assays are very sensitive. And as we incorporate some of the liquid biopsy, ctDNA testing at baseline, we usually don't see it at baseline, neither in the tumor nor in blood, but we usually see it a few months before you actually see progression on scan. So again, ctDNA is in many ways, predictive of progression a few months earlier before the actual scan. Right now, we're not necessarily acting upon just the liquid biopsy alone, but it's important to know that as you peel away the anti-EGFR, you could potentially re-challenge the patient with the same treatment and stop working. It does work in some, it doesn't work in the other. 2 years ago, we got some insight into this, and this was the outcome of so-called cricket study, which did cetuximab re-challenge. And what was intriguing in that result, and this is already published, where everyone who didn't respond, they had a resistant clone present in the blood. So they were plasma RAS or RAF mutant or EGFR mutant. Whereas everyone who responded, they were plasma RAS-RAF wild type. So remember, tissue, they were all RAS-RAF wild type to begin with. But on plasma, they became, so it's kind of like an interesting time where right now, in addition to talking about the tumor, you may also want to reflect upon before you re-challenge somebody with, cetuximab or panitumumab. These patients, especially with young onset colorectal cancer, are living for, at least 3, 4, if not longer years. So, you can imagine a tissue specimen from 4 years ago from a colonoscopy. How relevant is that if somebody had FOLFOX, panitumumab, again, another chemotherapy, and now you're talking about third line or fourth line? you may want to check their liquid biopsy status to make sure that they are still RAS-RAF wild type before you re-challenge them. Let's go on to the next slide and look at the results of the CAVE study. This is again looking at the same cricket concept of re-challenge of cetuximab holiday. Let's go on to the next slide, where this study essentially looked at immunotherapy, where cetuximab, there is some suggestion that that's a half mutant, half humanized, so maybe it activates antibody-dependent cellular cytotoxicity. So maybe the addition of avelumab in this situation may help augment responses. And they looked at similar ctDNA outcomes. Let's look at the next slide. And again, these patients, had prior anti-GFR therapy with cetuximab and panitumumab. As you can see, some of these patients had more than 3 lines of therapy. A lot of them were, not surprisingly, left-sided or rectal tumors because, as we know, for first line, anti-GFR is not recommended for use because of inherent resistance to anti-GFR, regardless of the RAS-RAF status. But as you can see in the bottom right panel, they do look at how many patients were actually RAS-RAF wild type on the in the blood, and surprisingly, a third of the patients were mutant. Again, dependent on how long was the prior exposure, because there's some elegant work from MD Anderson looking at the half-life of these clones, and it's anywhere between 3 to 6 months arbitrarily. So again, somebody may be mutant today, but you may want to check them again a little later in time and do something that's non-targeted to give them the benefit here. Let's go on to the next slide and look at some of the, again, this was a single arm study, so obviously there's no comparison, but we know that, patients in the refractory metastatic population from data from regorafenib and TAS-102, these patients, their overall survival as well as the PFS is not that long, but we saw, promising hypothesis generating responses similar to the data from a cricket study a couple of years ago, where the OS was upwards of 13 months and the PFS was 4 months. But more intriguingly, when they did the subset analyses looking at ctDNA positive versus negative, as depicted by the curves here, not surprisingly, if you were liquid biopsy positive for these mutations, the anti-GFR didn't help. If you were wild type, it did help. I don't know if the addition of immunotherapy adds anything, because the data, if you look at, compares very well to cetuximab re-challenge alone, that was done as part of the cricket study earlier without avelumab. But it's more so the concept of looking at acquired mechanisms of resistance that can fade away over time. Let's go on to the next slide. I just wanted to kind of share some examples of a patient of mine who actually had RAS-RAF mutations. Next slide. When I rechecked the mutational status, as you can see, the acquired mechanism of resistance faded away. So I was able to do what the CAVE study or the cricket study did by just giving anti-GFR when the resistant clones were not there. And it did work. Again, these are not cures by any means, but kind of re-challenging at a more appropriate time. Next slide. Again, another example of patient responding really well to anti-GFR blockade, developing resistance later. Just a switch of biologic led to response. In this case, it was an NRAS mutation acquired in Q61R. Next slide. We presented this data at ASCO a few years ago. Same data, same mechanisms, similar outcomes. So you could be more smart about re-challenging these patients when they actually don't have these mechanisms of resistance anymore, and could be RAS, RAF, EGFR mutations, could also be RAS amplification as depicted in the bottom pane in the middle. Let's go to the next slide. This is the half-life that I was telling you about. Again, the fact that somebody's mutant doesn't mean that you can write off the anti-GFR forever. 3 to 7 months down the line, if you were serially checking ctDNA, these clones can fade away if you did something that was non-targeted. Next slide. So concluding thoughts, essentially the theme and the topic that I was trying to highlight from work presented at ESMO is essentially looking at, the exciting area of survivals in terms of Keynote 177, but more so the recurring theme with the data pertaining to ctDNA, both in the MRD setting with trials. We spoke about the bespoke study was presented there, but we also now have the COBRA study, which is using another methylated permutational marker, which is activated through the NRG group. We have a Stand Up to Cancer grant with Dr. Parikh as the PI. So most important message would be to enroll to these trials that are open right now, because I think that would help inform care and how to use some of these assays, where I think it's getting beyond the sensitivity of the assay, and it's good to have this competition with many options, but more so that it's going to be the clinical utility and how to integrate it into practice that's going to be the key. With that, I'll pause here, and we can see if there are questions from our active webinar colleagues.
So thank you so much, Dr. Kassi, for that. I think there's such terrific insight into how we can start to use liquid biopsy as it is emerging, and as you pointed out, both in the adjuvant setting where you might be able to decide whether you require adjuvant therapy, but also in the metastatic where you do start to see emerging mutations that may be dealt differentially depending on the temporal progression of that patient. So I was sort of wondering, why is it that tissue still seems to remain the gold standard, and where we see ctDNA being so important and clearly sensitivity is an issue? What are the hurdles to it actually replacing tissue, particularly in tumors where tissue is you can't spare as much tissue?
That's a great question. I think it comes up all the time. I think inherently, I don't think liquid biopsy is meant to replace tissue biopsy, and vice versa. I think the tissue would always be gold standard, at least at baseline diagnosis, knowing about mutational profile. Dr. Takanaki is going to go into the PD-L1, the mismatch repair, other proteins. So for the immunohistochemistry, at least right now, tissue is gold standard for large gene rearrangements, as I showed earlier. ctDNA is great if it detects it, but the absence doesn't rule it out. And then obviously with these acquired mechanisms of resistance, it's not safe, feasible, or practical to be biopsying again and again and again. So in my mind, I don't think it's ever a comparator or concordance issue. It's more so when do you use which, especially for like right now for RAS-RAF wild-type tumors, post EGFR blockade. I think you have an opportunity to incorporate some of these assays in the metastatic settings. HER2 is one aspect that we didn't talk about in ESMO, but at ASCO and also published data. HER2 is also an acquired mechanism of resistance to post EGFR blockade, and right now is a flurry of HER2 blockade therapies coming out, both for upper GI as well as relevant for colorectal cancers who acquire it. So it's more so about how these complement each other. And for MRD, I think the key is going to be to enroll to trials, because some of the challenges that I brought forward is we don't necessarily know is MRD something that can be converted to negativity. I think a lot of these are anecdotal data, and that's what I think is the hurdle right now is we need to generate data and enroll to these active trials.
Great, thank you so much for that answer. And we'll get back to that discussion towards the end. Right now, I'll ask Dr. Catenacci to take us through some of the really seminal trials that read out at ESMO in upper GI.
Great, thank you. It's a pleasure to be here. And you can see here that at ESMO this year, we had some phenomenal data presented from 4 randomized phase 3 studies. So this is very exciting news for this disease, 3 of which were first-line studies and 1 that was an adjuvant study. And so we'll go through each of those, but also I'm going to spend about 5 to 10 minutes just with the background so that we understand where we were the day before ESMO, just to set the stage. So next slide. We know that there's a number of chemotherapeutic agents that are effective in this disease in controlling stage 4 disease. They're listed there at the top. And there are a few targeted therapies that are approved. Those are listed here in green: trastuzumab in first line, ramucirumab in second line, and then pembrolizumab in second line for MSI highs, and any solid tumor, but including this disease. And then in third line with PD-L1 score CPS 1 or higher. So we'll take you through some of the data that led to those PD-L1 approvals. Next slide. So this is the landscape of studies just before ESMO. And you can see in the first line as maintenance studies, second line or third line. And I'll just briefly overview some of these studies and the pertinent points before we got to the new studies that were presented at ESMO. So next slide. Next slide. So this is a little bit of a busy slide, but what you can see in columns is the first line, second line, and third line studies. And then by each figure is sort of the survival plot when available. The Keynote 181 study there doesn't have the adenocarcinoma survival plots public. And what we saw there in the studies, all of these, you can see this phenomenon of crossing of the curves, especially when compared directly to chemotherapy. So some examples there are Keynote 61, Keynote 62, even in Javelin 100, which was the maintenance study, where initially there's a bunch of patients that did worse with the immunotherapy drug. And then later on, there's a crossing and some patients are doing better with the immunotherapy drug by itself as immunotherapy monotherapy. And some other things we've learned are that the PD-L1 score, the higher the level essentially, the more likely that patients would benefit. And so this actually led to approvals in the US based on that Keynote 59 study on the right side in a single arm study, not randomized, in patients with CPS scores of 1 or higher. So that's where the approval is outside of MSI highs and third line and MSI higher. Nivolumab was approved in Asia in an all-Asian study based on that Attraction 2 study in the top right. But because there were no patients enrolled outside of Asia, this was not approved here. So in addition to that, then the higher levels, and you can advance, in the Keynote 61 study, if you advance forward, that see in the middle section there that the CPS 10 or higher cutoff seemed to enrich for patients to benefit and actually excluded those patients who seemed to not benefit. So this was more reassuring that we weren't doing harm by not giving chemotherapy to begin with to some patients. However, and you can advance again, in Keynote 62 on the top left, this study, when you looked at the 10 or higher subgroup, it still had that initial group of patients that seemed to not be doing well compared to chemotherapy. So based on these studies, there were no approvals in earlier lines of therapy yet for immunotherapy monotherapy in second line or third line for gastric and G-junction adenocarcinomas, which is what this slide is showing. So next slide. To blow up that a little bit closer, you can see that Keynote 61 study in second line, where in addition to on the right side, you see the plot of the CS1 or higher, which you saw on the first slide. In the CPS 0, those patients who were negative, who are also eligible for the study, you can see that essentially they were doing worse than chemotherapy. And so this study, part of the study was terminated early. And so, you know, we're not doing any favors to patients giving immunotherapy just because it's immunotherapy when you see outcomes like that. And then next slide, you see the CPS 10 or higher cutoff, again, that I had shown in the blow up that seemed to enrich for patients who might be doing better, at least in this second line Keynote 61 study. And then next slide, at the CPS 5 or higher cutoff, which we saw for the first time at ASCO this year, we see that it also seems to mitigate this, the yin part of the yin-yang curve. However, it sort of still includes the 10 or higher, and the performance of just those CPS 5 to 10 cutoff is a little bit unknown because it's buried in there. So next slide. The other thing to note here is that the incidence of these particular cutoffs is about 60% with 1 or higher, 15 to 25% in the 10 or higher, and then advance one more, you see that above 5, it's about 35%. Now advance one more, this is with a specific antibody called the 22C3 antibody that has been coupled with Pembro and the Merck studies. Next slide. And so moving on to another relevant study to set the stage for the Keynote 590 study that was reported at ESMO. This is the Keynote 181, which was the second line study of esophageal squamous cell, esophageal adeno, and GE junction. So there is some overlap here in eligibility for that Keynote 62 study, which also had GE junction adenocarcinomas and even esophageal adenocarcinomas, frankly. So what you can see here are survival plots from all comers, irrespective of PD-L1, and including both adeno and squamous histology. You see by just squamous histology, and you see by cutting off at CPS 10 or higher in any histology. And so what you can really see here is that in all comers, it was not considered statistically significant. These types of curves I've sort of dubbed, they're not yin-yang curves, at least in this study, but rather they're more like crescendo plots, where on the far left, you're seeing very minimal benefit in many, many patients compared to chemo alone. But then as you go later, you see people having more benefit from immunotherapy versus the chemotherapy. But when you cut off at 10 or higher, you can see the benefits become more substantial. And this is irrespective of histology. However, next slide, when you look at the subgroup analysis, and you can advance, in the intention to treat arm, you see that really all the people who are benefiting are squamous cell, above 10, and Asian patients. All the other reciprocal groups are on the line of the hazard ratios. And we don't make huge deal about this in forest plots until we keep seeing repetition of the same patterns. And as I go through this, you're going to see the same pattern. So amongst the squamous cell patients, you can see still, even amongst squamous cell, that it's really the above 10 and even the Asian patients that drive benefit. And then when you look amongst those patients who have PD-L1 above 10, it's the squamous and those among that are above, that are from Asia, and the adenocarcinomas don't really drive benefit. Again, the adenocarcinoma population that was above 10 in this study was about 25% of adenocarcinomas are going to be CPS 10 or higher by this antibody. Next slide. So moving on to another important study is the Attraction 3 study, which was looking at esophageal squamous cell cancer. And this was essentially done only in Asia. You can see there that there's literally 18 patients that are non-Asian on the study. So it's not really represented outside of Asia, I would say. And you can see here actually a mini yin-yang plot. This is again immunotherapy, single agent and second line versus chemotherapy. And so you can see here that even by the PD-L1 scores up at the very top of the forest plot, although the conclusion was that it doesn't help to enrich, you can see that at any cutoff, 1%, 5%, or 10%, that the higher levels seem to drive more benefit. And this is by, and advance, this is by a different scoring system. You can advance forward to by TPS scoring. So tumor positivity scoring as opposed to combined positivity scoring, which I'll go into in a moment, and with a different antibody that is coupled with nivolumab and the Merck the BMS studies. So this led to approval, though, in all comers in the second line setting for squamous cell in the United States, irrespective of PD-L1 status and irrespective of having very few patients that were represented outside of Asia. Next slide. So again, back to the first line study now, Keynote 62, which was now in the in the G junction and then the stomach. This was the first study in the first line setting to read out, and it's recently been published. And this study, the pertinent things are that it only enrolled patients that were CPS 1 or higher. It had 3 arms, one of which was pembrolizumab alone, one of which was chemo plus placebo, and that's what you're seeing right here on these curves is chemo versus pembro. And again, we see the yin-yang plot, which I showed you at the very beginning, both at the original intention to treat 1 or higher, but also at the 10 or higher. And then next slide, we see the comparison of chemo with or without pembro. So chemo plus pembro versus chemo plus placebo. And this was the first and only study to date that had any chemo plus pembro or any immunotherapy drug before ESMO. And certainly it was the only one in the first line setting. That was a phase 3 study. And what you see here is that although you see a trend to benefit, it's sort of like a mini crescendo. And it had a hazard ratio of 0.85, but not considered statistically significant. And so this study did not lead to any approvals of pembrolizumab in first line. Next slide. Even when you look at CPS 10 or higher, it still didn't make the mark in terms of a significant benefit. And so advance. So you can see here that these crescendo plots didn't lead to approval, even though there's a group of patients that likely do better with immunotherapy plus chemo to begin with. I'll also point out that the size of this study is only 250 patients per arm. And then when you look at the 10 or higher, which is a small percentage of that, it's only less than 100 patients per arm. So not a lot of power to detect relatively small differences. Next slide. So a word about PD-L1 scoring, because it's important to understand and contrast all these studies. And PD-L1 22C3 antibody is currently the only FDA-approved diagnostic antibody for pembrolizumab in the third line setting for a CPS score of 1 or higher. And you can see the combined score is not only tumor cells, but also infiltrating immune cells. And on the bottom, what you see is the contrast of what a combined positivity score would score as positive or negative, and what a tumor positivity score would score as positive or negative. So there will be circumstances where they're concordant, like on the left, far left, where you have a lot of tumor cells and immune cells, the tumor cells being big circles and the immune cells being small circles staining. And so both of them could possibly be positive. And on the right side, you have a situation where all the cells are negative. So both of the scores will call this negative. However, in the middle, the red part, is when you would see discordance is that the tumor cells are negative for staining, but the immune infiltrate is positive. And it's interesting to note that, as Dr. Kazi mentioned, MSI high tumors, which are probably the most sensitive tumors to immunotherapy, are most often in that middle category, or many of them are. So the ones who derive the most benefit would be called negative by TPS scoring. This is very important to understand. So, and again, this is by the 22C3 assay. That's been the one that has been scoring in this manner up until ASCO. Next slide. So as a summary, you can see on the left, the studies and their drugs, and then the diagnostic antibody names, the scoring systems that were used in their cutoffs, and then the positivity incidence. How often is a patient's tumor going to be this score based on the various cutoffs? And you can see that as you increase the cutoff of CPS scoring, the less frequent it is and the less incidence it is. However, it enriches for more benefit, the more likely patients will derive benefit from it. However, so the other thing on the top right is to say that there's a good negative predictive value if your CPS score is 0 by the 22C3 antibody, which is about 40 to 50% of patients' tumors. Their chance of benefiting from monotherapy is very low based on all these studies we just talked about. And the last thing to point out on this slide is that the other antibodies and studies were always just using tumor positivity scoring, and they always never really showed any predictive value of that scoring system. Next slide. So to summarize where we were at, not that long ago, we see that, we have HER2 testing, we have CPS testing, we have MSI testing, and we sort of stratify patients into different molecular groups based on their biology and give them therapies that are pertinent to their disease. So trastuzumab in first line for HER2 positive, and pembrolizumab in third line, pembrolizumab for MSIs in second line, and then advance forward. You can see that immunotherapy in second line, first line maintenance in first line had known benefactors of it, but also known patients that would not benefit from it from not selecting well. And so no approvals to date. And then Pembro, even though it was approved in second line, as Dr. Kazi mentioned, of all the patients that should get these drugs, these are them, and they should get it as soon as possible. And so advance a little bit, and you can see that many of us had already started doing this immediately as soon as we learned that they had an MSI high tumor. Next slide. So that brings us now to 3 first-line studies that were done as reported at ESMO. And you can see the study sizes, and you just look at the comparison of them. And then you can also see that there's 2 other studies that are still ongoing that we expect to read out at some point that will add more information to help direct us on who should be getting these drugs. So next slide. So the first one is the Keynote 590 study. It's a study that's very akin to the second line 181 study. And that study included patients with esophageal squamous cell, esophageal adeno, and G-junction adenocarcinomas. And you can see there that the treatment was basically chemo versus chemo plus Pembro, but it was placebo-controlled, and the endpoints were overall survival primarily. Next slide. And some pertinent things to note are that more than 50% of patients were from Asia, almost 75% of patients had squamous cell, and more than 50% of patients had a CPS score above 10. Next slide. So what you see is that of squamous cells with CPS above 10 do the best, which is not surprising. And that is a really pronounced crescendo plot where even on the left there's benefit. However, when you include all squamous cells, irrespective of PD-L1, that crescendo plot gets attenuated. Next slide. And then when you look at patients who just have CPS 10 or higher, it's a pretty nice plot. But when you add all patients, irrespective of PDL1, the curves get attenuated. And I'll just point out on both of these examples, the hazard ratios go from 0.5, 0.6 up to 0.7s. And so what does the other group that was added to these patients doing very well have to be to drag the average to this number? So another way to look at that is the next slide, the forest plots. So advance a little bit, and you can see that these forest plots are very similar to the Keynote 181 study. The Asians versus non-Asians deriving the most benefit. CPS 10 higher, deriving most of the benefit. The one little difference is that the adenocarcinoma, instead of being on the line like in 181, is now pushed over a little bit to the left. And advance a little bit, and when you look down deeper, we see that the CPS above 10 makeup of these adenocarcinomas is almost half of them, as opposed to a quarter of them in the 181 study. So maybe that has a role into why the adenocarcinoma as all comers is pushed over. So we really need to see these data broken down by these variables, because it's the same pattern every time. And I'm going to sound like a broken record because it's the same thing with every study I'm going to go through going forward. Next slide. So the next one quickly is Attraction 4. This was a first-line study also with chemotherapy with a regimen of Capox or SOX, which is an oral version. S1 is an oral fluoropyrimidine available in Asia. This is a study where it was completely done in Asia, and it was placebo-controlled with or without nivolumab. Next slide. And you can see sort of the forest plot here. All patients are from Asia, and you can advance. Unfortunately, they don't present the data by CPS scoring. It's only TPS scoring. Next slide. You see that the primary endpoint of progression-free survival was met, adding about 60 days median survival advantage. And next slide. You see, unfortunately, that the overall survival co-primary endpoint was negative. And some of the points to just note here is that Asians tend to do very, very well, much higher median survivals than what we would expect in the Western side, with median survival of 17 months in all comers, irrespective of PDL1 status. Next slide. So the next and important study is Keynote 649. This was again a study of G-junction adenodes and gastric cancers. What I'm showing here on the left are an abstract from 2017 on the top and then 2018 on the bottom that were trial in progress abstracts. And what you can see is there was a major amendment from the original protocol as the trial was accruing, and that was to add a third arm, and you can advance. That is with chemo plus nivolumab, whereas the original study did not have that. It was just nivo-ipi, chemo-free versus chemo. And so that was a major amendment. And then next slide, and next. Another major study amendment was that the nivo-ipi arm was terminated. We don't know a lot about that because it's not public and we've not had any reports yet, but we do expect that soon. And then also the size sample was higher now in the chemo comparison arms of the chemo with or without nivo. As a default of the original design, which was not placebo-controlled because it could not be the way you looked at the study, there's no chemo backbone in the investigational arm. This sort of got grandfathered in now as a non-placebo-controlled study because of the addition of the nivo plus chemo. Next slide. So this was the actual final version that was presented, where you see 3 arms, 2 of which we've seen, just the chemo comparison of almost 800 patients per arm. And the primary endpoint also changed again now from a TPS of 1 or higher scoring to a CPS of 5 or higher scoring. So some big changes along the way throughout the duration of the study. Next slide. And so what we see, just some pertinence, 25% patients Asians, 70% gastric, MSI high, right where we would expect it to be in the stage 4 setting, about 3 to 4%. Next slide. And we see a nice curve in the amended new primary endpoint of chemo plus nivo versus chemo, where we see an improvement of over 3 months median survival. Next slide. However, when we start looking at adding patients above the CPS score of 1 or all comers, you can see that as you add those few patients to the whole in that top right box, that the hazard ratios start increasing. And so you have to ask, what are the individual hazard ratios of just the groups between 1 to 4 and the patients that are CPS 0 to be able to draw the whole curves down like that. And I think we would all like to see that. And you can see the attenuation of these crescendo plots in this situation on both of these analyses. Next slide. And so unfortunately, in the actual forest plots in the middle bar, we see that it's TPS that's being represented and not CPS, which is what we'd really like to see, which would help answer those questions that I just mentioned. You can also see that MSI high tumors, as Dr. Kazi mentioned, they do extremely well, hazard ratio of 0.33. And then finally, next advance, you can see that in a comparison as to why would the Attraction 4 study be negative for survival and the Checkmate 649 study be positive. There's a lot of reasons. One is that Checkmate 649 is selecting for patients by CPS 5 or higher, whereas Attraction 4 is all comers. Also, the notion that patients are getting crossover more frequently in Asia, as is shown in the bar graphs down below on the bottom right, where on the Attraction 4 study, more patients get second-line therapy and more patients get second-line immunotherapy. So that can lead to dilutional effect later on from the survival evaluation. However, when I point out a race there in the red bar of the forest plot, the Asians of the Checkmate 649 study have the best outcome. Their hazard ratio is 0.63 and their median survival with Nivo chemo 16.1 and with chemo alone is 11.5. So then the next question would be are these Asians different than the Asians in Attraction 4? Did these ones not cross over to the same degree? And why would that be? Why would these be any different? These are questions we don't know the answer to, but this only as being the variable as to why and explaining these differences doesn't actually explain the difference. Next slide. So to add here now, you can see where the CPS score, can you advance? I think I highlighted it oh, maybe not, go back. So the CPS combined positivity score amongst the Checkmate attractions now, we see the CPS above 5 is 60% of the patients as opposed to CPS 1 with a different antibody of that 60% of the population. So there's different incidences now with different cutoffs, and we're not sure exactly why, but it could be that the antibody is more sensitive and calling more patients' tumors positive, or it could very well be that more patients were pre-selected before enrollment based on the ubiquitous nature of these assays being around, and then funneling patients that happen to have CPS scores into the study so that it looks like an inflated artificial incidence rate. And I don't know if we're ever going to be able to tease that out, at least in the immediate future. So next slide. The last and most important study, I think, is the Checkmate 577 study. This was an adjuvant therapy study with squamous adeno and G-junction adenos. And the important points are that it enrolled patients that were stage 2 and 3, had neoadjuvant chemoradiation and an R0 complete resection, and that they had to have not had a path CR. So they had residual disease, either YPT positive or YPN positive or both. And these patients are high risk, we know, with a very poor disease-free and overall survival. And so patients were then randomized 2-to-1 to Nivo or placebo. So a nice design, all comers, irrespective of PD-L1 status, although that was a stratification factor by TPS scoring. And the primary endpoint was disease-free survival. Next slide. And so what you see here is that, in contrast to many of the other studies, most of the patients here are not Asian, that 40% of patients are G-junction cancers, mostly adenocarcinomas probably, which is representative of our practice. Most of our patients are that in the West, not squamous. And there's a 71% adenocarcinoma tumors. Unfortunately, it's not presented by CPS scoring, only TPS scoring, which I think we need to see. Next slide. And we see a nice outcome with an improvement in median disease-free survival of double for disease-free survival. That said, there are a couple of things to mention is that this is what I would dub a tuning fork plot, where you see at the far left, not only is it a crescendo, but it's actually like the same as doing nothing, just placebo. So those patients derived zero benefit from nivolumab. Can we potentially identify who those patients are? And we'll talk about that in the next slide. And then the next, so we see this here, that the forest plot shows that, as expected, the esophageal cancer group, as compared to the G junction, which is sort of a surrogate for squamous cell versus adeno, really show clear differences in outcome. And then in the adeno versus squamous, you again see that the driving force, as is not surprising, is squamous cell. And you have to mention also, this is irrespective of PD-L1 status. So advance, and the questions that linger are, what are these outcomes looking by CPS, by histology? And so this is very important before I commit my patient to a year of nivolumab to really know it's helping them, because those tuning fork plots may become even more pronounced in low-level PD-L1 and especially adenocarcinomas, where it may look very underwhelming. So until I see those data, I'm not going to just change my practice based on a disease-free survival endpoint that's lumping in patients who we know are doing very, very well. And so longer follow-up, overall survival are key, of course, and seeing this all by CPS scores, I think, are very, very critical. Next slide. So I'm going to summarize based on the first-line studies that are looking at these 4 trials, the 3 new ones plus the previous Keynote 62, and contrast what we're seeing. So what you see in the size column, the one that's striking is the Checkmate 649, which is a massive study compared to the others and able to find small differences with higher power. There was a lot of talk about oxaliplatin being the reason why some studies are positive and others negative, but we know Keynote 590 was positive, and we know Attraction 4 was negative, so that doesn't really resonate with me very much. We see the placebo argument, which is sort of the elephant in the Zoom, I like to say. You know, it is what it is. It sort of was the way that that evolved from how the trial started. You can see the squamous adeno breakdown, the histology breakdown, the Asian breakdown, and all the heterogeneity of the biomarker looks and the incidences and the way they're tested by antibody and all the heterogeneous outcomes. And so it's very challenging to sort of digest all of this. And I think as we see the publications, more data, and especially by histology and especially by CPS scores, I think that what we're going to see is what we would have expected, which is the higher benefits are amongst the high PD-L1s and the squamous. Next slide. So to summarize, we know squamous do better than adenos. We know the higher the PD-L1, the better. Asians tend to do better than non-Asians. Non-placebo did better than placebo, and the chemo backbone didn't really make much difference. Next slide, and last slide. Is, in my view, in what's going to change practice, at least in the very near future, are in green of each of those studies. And then I will withhold my opinion until I see the data of those other groups before I comment on whether or not I think it's warranted. And I'll stop there.
Great, thank you so much, Dr. Katnash. You did a really thorough review, and we have a ton of questions. I know we're almost up on time, but I think everyone wants to have those questions answered. I think, you know, if I was just to pick one, taking Checkmate 577, if, you know, holding histology inequality as a factor, the fact that the trial used DFS as a primary endpoint and not overall survival, what does that, how much confidence do you have in that as an endpoint? And then what does that imply for what a patient might receive if they do progress to the metastatic setting?
Both very important questions. And, you know, I do think DFS is a reasonable endpoint to have for this disease, especially now that we have, well, we have data to show that that is a good surrogate for 5-year overall survival from analyses that looked at that. Secondly, we have a lot of good options now in the metastatic setting. We just talked about a whole bunch of studies that improve outcomes in the first line setting, and we have known new therapies in second line and third line, et cetera. And so survival in the palliative settings also increase. So that would dilute out benefits in terms of survival and overall survival. So I think DFS is okay, you know, especially if there's a plateau on the curves, which it appears that there is, and that seems to be that they're not recurring. That's actually more pure as a cure rate, as opposed to overall survival where patients are alive but with cancer that has recurred. So, and then in terms of your second part of that question, the recurrence risk, and when they do recur, what about now you've just failed Nivo, are you going to give more Nivo? And so the answer to me is, or more immunotherapy, say. And the answer is similar to what I would do if it was a chemo question and the patient recurred like within a few weeks of completing their adjuvant Nivo or during that year of adjuvant Nivo, I don't think I will be continuing Nivo in first line because that doesn't make a lot of sense. On the other hand, if it's been 2 years since they had Nivo and they recurred, and they had biological factors like high PD-L1 or whatever to suggest that IO could be beneficial, I might consider it in that situation.
Great, thanks. Thanks so much. And we have a question for Dr. Kasi. For EGFR re-challenge, might monitoring the ctDNA for KRAS mutations to see an early sign of progression be something to consider so that stopping therapy might minimize disease burden or progression, or disease burden with progression, I should say?
This is a perfect question for a clinical trial right now. I would say, borrowing a page from our colleagues in lung cancer and other cancers where they use targeted therapies more often than us, this is something that is increasingly being recognized, where mechanisms of resistance can be molecularly detected before radiological progression. And it would make sense to act early. However, I think we don't have any data to support that for colorectal cancer. Like I said, this would be a perfect question for a prospective trial. The timing's right.
Great, and I think another burning question is when we might expect the Signatera assay to enter standard practice.
So, from an approval standpoint, it already got Medicare approval for the MRD setting that we are talking about. And also it got draft approval for ctDNA monitoring during immunotherapy. However, like we discussed earlier, I think while the assays are available through either, right now with Medicare approval, technically you can bill the patient for the assay. But, and with expanded access programs, you could use it for other tumor types, including esophageal cancer, like outlined. But I think this is a perfect time to be enrolling in any of the mentioned trials, whether it's the bespoke study using the tumor-informed assay, the COBRA study, which is through the NRG cooperative group. It's pretty much open everywhere, community or academic practice in the country for stage 2A colon cancer. And then we have the Standard of Cancer Grant looking at, again, the question of ctDNA positivity through in-house assays. I think within your area of reach or your cancer center as a patient or a patient advocate or an oncologist, I think we have access to one or more than one trials. I would enroll in trials right now so that we can really inform data, as opposed to some of the other, tests that came out for NGS for metastatic. We never really had a trial, so that question always remains unanswered in terms of, how much value does NGS testing has it, we know it helps and it helps a subset, but what's the impact? I don't think it has been shown clearly in a prospective study. Things were approved before it even got into a trial. I think with some of these other assays, we have a unique opportunity to participate in trials to really gather that prospective data.
Great. I think, at this point, there's so many other questions.
Yeah.
I think we might just want to wrap here just to say this is just an indication that upper GI is clearly a focus right now, and it's been really truly insightful to listen to your thoughts on these various trials. I think we'll be following what's going to happen in the front line as well as the adjuvant settings for across these tumors, as well as GI overall. So I just want to thank the both of you for your time today. And I'd also like to thank all the attendees who stuck around and who asked some important questions. We'd just like to remind everyone that as part of this ongoing series from Axiom, that the next session will be on lung cancer today at 5 p.m. Eastern. So once again, thank you so much, Dr. Kasi, Dr. Katnachi, and have a wonderful day, everybody.
Thank you.
Thank you.